All right, let's talk about one of the most intense, high stakes emergencies you can possibly face in medicine: cardiac arrest during pregnancy. I mean, we're not just talking about one life here, we're talking about two. And believe me, the clock is ticking like you wouldn't believe.
So, what do you do? I mean, cardiac arrest is already the ultimate medical emergency, right? But now you've got two lives hanging in the balance. The basic rules of resuscitation, yeah, they're still our foundation, but pregnancy throws this massive curveball, a physiological challenge that just changes the entire game. Every single move has to be faster, more precise, and way more decisive. Okay, so here's the absolute heart of the problem. It's something called aortocaval compression. Basically, once you get past about 20 weeks of pregnancy, the uterus gets big enough that it literally starts squishing the body's two main blood vessels, the aorta and the inferior vena cava. Think of it like someone standing on a garden hose. This can slash the blood flow getting back to the heart by a third, maybe even more. So even if you're doing perfect chest compressions, you're not getting enough blood back into the pump. This is the one problem we have to solve right now. So, knowing that's our biggest enemy, that compression, our first actions have to be lightning fast and super specific. We're talking about taking the fundamentals of life support and giving them a critical tweak. And this has to happen the second we know the heart has stopped. And here they are, the big three things that have to happen all at once. First, you start high quality CPR. And just a quick note, you're going to do it a little higher on the chest because the diaphragm's pushed up. Second, you hit the panic button and call in the cavalry, the special maternal arrest team, OB, neonatology, anesthesia, the whole crew. But third, and this is absolutely crucial, happening at the exact same time, you have to do this: manual uterine displacement, or MUD. And this, right here, is the solution to that huge compression problem we just talked about. All it means is that someone on the team physically pushes the uterus over to the patient's left side, getting it off those big blood vessels. It sounds so simple, but it is the most important initial step. It can make CPR go from basically useless to actually effective. It's not just a good idea, it's the key that unlocks the whole resuscitation. Okay, let's talk advanced life support. Airway is priority number one. Pregnant patients are at a higher risk for a difficult airway and aspiration, so you need your most experienced provider on that, like yesterday. For IV access, you have to get it above the diaphragm. Think about it. If you put it in the leg, the drugs might never make it past that compressed zone. And here's a super important point. Don't hesitate on the standard stuff. Defibrillation, drugs like epinephrine, you give them just like you normally would. No delays. The number one goal here is saving the mother. All right, so let's picture the scene. We're doing great CPR, we've got the uterus displaced, and the ACLS protocol is rolling. But what if we don't get the heart started again right away? What if we don't get that return of spontaneous circulation, or ROSC? Well, that's when a new clock starts ticking. And this one is a countdown to the most dramatic, most definitive intervention of all. And this timeline, this is everything. It's called the 4-minute rule. If you've been doing high-quality resuscitation for 4 minutes and the mother's heart hasn't started back up, you have to make the call to begin delivering the baby. And look closely, the goal isn't just to start by minute 4. The goal is to have that baby delivered by minute 5. The urgency here is just off the charts. There is no time to waste. 5 minutes, that's the number. It's burned into the brain of every single person on a maternal arrest team. And it's not some random number we pulled out of a hat. It's based on physiology and real-world cases that show after 5 minutes, the chances of a good outcome for both mom and baby just plummet. So, we're hitting that 5-minute mark, and this incredibly intense procedure is happening. But why are we really doing it? It's so easy to think it's all about saving the baby. But that's actually a huge misunderstanding of the primary goal. The procedure is called a resuscitative hysterotomy. It used to be called a perimortem C-section, but the new name really tells you everything you need to know. It is a resuscitative procedure. See, by getting the baby and the placenta out, you instantly relieve all that aortocaval compression. It's like taking your foot off the hose. You can get this huge surge of blood returning to the heart, and sometimes that's all it takes to get the mother's circulation back online. And this quote just nails it. The primary goal is maternal resuscitation. You're trying to save the mother. Because here's the thing. Maternal survival offers the absolute best chance for the baby's survival. You're not choosing one over the other. You're saving mom to give the baby its best and really its only shot.
And another thing that's so important, this has to happen right there, on the spot, in the ER and the ICU, on the floor, wherever the arrest happened. There is absolutely, positively no time to waste moving the patient to an operating room. Any delay completely defeats the purpose of that 5-minute rule.
Okay, wow, that was a lot. An incredibly intense sequence of events. So let's pull back and summarize the most important things to remember. Because while this is going on, the team is also frantically trying to figure out why this happened in the first place, searching for any reversible causes.
So we've always got our standard checklist for reversible causes, the H's and T's, things like hypoxia or a blood clot. But for a pregnant patient, we add a whole other layer to our investigation. We call them the 4 P's. We're looking for things like preeclampsia, puerperal sepsis, placental problems like an abruption, or peripartum cardiomyopathy. Finding and treating one of these might be the magic bullet that gets the heart started again.
All right, so if you walk away from this with only a few things locked in your brain, make it these 4. Number 1, displace that uterus to the left, always. It's the move that makes everything else work. 2, don't mess with the basics. Standard CPR, drugs, and shocks are not delayed. 3, that 5-minute clock for delivery, if you don't get ROSC, it's not a suggestion, it's a hard and fast rule. And finally, number 4, remember why you're doing that delivery. The primary goal of the resuscitative hysterectomy is to save the mother. This scenario is the ultimate medical race against time. It's not just about knowing the steps in a textbook. It's a low-frequency but incredibly high-acuity event that demands a perfectly coordinated team. So the real question is your team prepared to execute this flawlessly when everything is on the line? Because in this situation, preparation is truly everything.